chairs and audience. In the next few minutes, I would like to introduce the 6-month progress of our research about optimizing the time of cord clamping and the dosage of caffeine among preterm infants. My name is Gréta Mayor. Currently, I'm a first-year PhD student, and I'm working at Heim Translational Pediatric Institute. My supervisor is Ákos Gasparics, my SMS is Mark Hernátfői, and my statistician is Ádám Zolcsák. My vision is to improve the quality of life and extend the life expectancy of the preterm infants. To achieve that, optimizing the time of cord clamping and the dosage of caffeine among preterms are my missions. Now let me introduce you my 2 ongoing projects and specific goals to complete my missions. My first project is about investigating the outcomes of neonatal resuscitation with and without intact cord. According to the guidelines based on the ICOR recommendations for those preterm and term infants who do not require resuscitation at birth, delayed cord clamping is or may be reasonable. Delayed cord clamping is associated with significant neonatal benefits, such as improved transitional circulation, decreased need for blood transfusion, and lower incidence of necrotizing enterocolitis and intraventricular hemorrhage. Most newborns breathe spontaneously after birth, but around 15% require some degree of active resuscitation. The need for active resuscitation is inversely related to the gestational age, so for example, for the very preterm neonates, it is approximately 85%. Unfortunately, for these preterm and term infants, we have insufficient evidence on the optimal time of cord clamping. So our aim is to determine whether intact cord provides physiological, neonatal morbidity, and mortality benefits for infants requiring resuscitation at birth. Our clinical question is, how does starting resuscitation with intact cord change the neonatal and maternal outcomes? We hypothesize that starting resuscitation with intact cord decreases the incidence of neonatal mortality and morbidity and increases the oxygen saturation level and heart rate at 5 and 10 minutes after birth. We conducted a systematic search in 4 main databases on 19th of November with the search key of 2 domains, one for the umbilical cord and one for the resuscitation. It resulted around 16,000 hits, and after the selection processes, we had 10 eligible articles. With the reference checking, we didn't find any further eligible ones. Here you can see the list of our ongoing and finished analysis. We have a total of 31 outcomes, and we are planning to have subgroup analysis based on the gestational age and on the type of intervention in the control group. So now let me show you the results of our finished analysis. First, I would like to say some details which are common in the next 4 forest plots. We are examining how resuscitation before and after cord clamping affect the neonatal outcomes. For effect measure, we use odds ratio. If the odds ratio is 1, then it means there is no difference in the effects of the 2 groups. If the odds ratio is above 1, then it means the event is more common in the intervention group, which is the intact cord resuscitation group. If the odds ratio is below 1, then the event is more common in the control group, which is the cord clamping prior to resuscitation group. All studies are RCTs. On this first forest plot, you can see the result of one of the hardest outcomes, the in-hospital mortality. A total of 5 studies were selected for the analysis with around 600 patients. The first 2 studies' confidence intervals are wide, which is probably due to the lack of event in the intervention groups. The other 3 studies are quite homogeneous. The heterogeneity is not statistically confirmed. The overall odds ratio is 0.87. This result is nor clinically neither statistically significant. Our second and third outcomes are both intraventricular hemorrhage, but we separated it to all grades and severe, which means grades 3 or 4 IVH. Unfortunately, IVH remains a major complication of the prematurity. First, let's see the all grades of IVH. A total of 3 studies were selected with 300 patients. The population is quite homogeneous, and the odds ratio is 1.34, which means a 34 higher odds for the all grades of IVH in the intact cord resuscitation group. These results may be clinically significant, But unfortunately, the total sample sizes are small. We could include only 3 articles, and also the result is not statistically significant. Regarding the severe IVH, we have 4 studies for the analysis with around 320 patients. The total sample sizes and event numbers are small, and there is a lack of event in the intervention groups of the first 2 studies. The overall odds ratio is 0.94. This result is nor clinically neither statistically significant. Our 4th outcome is the need for blood transfusion. As I previously mentioned, delayed cord clamping is associated with decreased need for blood transfusion, which can be a significant benefit for the newborns. A total of 4 studies were selected with around 320 patients. The overall odds ratio is 0.91. This result is also not statistically nor neither clinically significant. After our results, now let me summarize our strengths and limitations. First, I would like to highlight the former ones. We included only RCTs and examined the broad population, preterm and term infants also. We have a high range of outcomes, and we are planning to have detailed subgroup analysis. We also have some limitations as well. These are the small sample sizes and event numbers, the different definitions of the outcomes, and the heterogeneous protocol of the intervention. In summary, based on our results so far, it seems like intact cord resuscitation is non-inferior compared to cord clamping prior to resuscitation. We recommend that intact cord resuscitation probably can be used safely among preterm and term infants, and we also recommend the revision of the current guidelines. In the research field, larger sample sizes and standardized protocol of the intervention are needed. Here you can see our progress. I'm at the grade assessment phase currently. After that, I will start writing a manuscript. You can see the deadlines and our chosen journals here. In the last couple of minutes, I would like to say some words about our second project as well, which is about comparing the effects of different dosages of caffeine on neonatal mortality and morbidity. Caffeine therapy is widely used among preterm infants, as it is effective in reducing apnoea of the prematurity, need for and duration of mechanical ventilation, and decreases the incidence of bronchopulmonary dysplasia. Due to the possibility of serious neurological side effects, the caffeine for apnoea of prematurity shortly kept trial was conducted. They found that there was an improvement in the rate of survival without neurodevelopmental disability in long-term follow-up in patients who received caffeine therapy. Of course, there are other possible side effects as well, such as feeding intolerance, necrotizing enterocolitis, intraventricular hemorrhage, bloating, or tachycardia. The commonly prescribed dose is 5 mg per kilogram per day caffeine citrate, but there is still uncertainty regarding the optimal dose. In the available research papers, there is a wide range of the used caffeine maintenance dosage from 3 to 20 mg per kilogram per day. So our aim is to compare the clinical effectiveness and side effects of different maintenance doses of caffeine therapy in preterm infants. The clinical question is, what is the optimal maintenance dosage of caffeine citrate for extremely and very preterm infants? We hypothesize that the administration of higher dose than the commonly used 5 mg per kilogram per day of caffeine citrate improves survival, decreases morbidity without worsening side effects. The clinical implication is determining the optimal dose of caffeine for preterms, and this way a decrease in neonatal mortality and morbidity. On this slide, you can see a short summary of my previously described projects. And I would like to finish my presentation with one of my favorite quotes by Ray Goforth, which is, "There are 2 types of people who will tell you that you cannot make a difference in this world. Those who are afraid to try, and those who are afraid you will succeed." Thank you for your attention.
You used the term of resuscitation. Was it the same step what they reached all along the studies? Or the definition of the resuscitation was the same?
Yes, thank you for your question. We considered everything as resuscitation further than drying and stimulation. These could be, for example, airway opening maneuvers, positive pressure ventilation, intubation, or chest compressions. These could differ in the articles due to the need of the infants, of course, but in most studies there was an initial CPAP or positive pressure ventilation.
Sorry, can I have one more question?
Sure.
And there is just regarding the different strategies of the cord clamping methods. Have they defined how many minutes they wait, or have they evenly mentioned that?
Yes, of course. In the intervention group, there was a huge heterogeneity in the time of cord clamping. It could happen at 50 seconds, or at least 60 seconds, at least 180 seconds. And there was one study where they performed physiological-based cord clamping. It means they clamped the cord only when the infant was judged to be stable. This means there was a presence of regular spontaneous breathing, heart rate above 100 beats per minute, and oxygen saturation higher than 90%, with the supplement oxygen below than 40%. So in this study, the timing of cord clamping was around at a mean of 6 minutes.
Do we have any local or national protocol for the cord clamping here in Hungary regarding resuscitation or without that?
I think we are using the international protocols, and this is, as I said, for those who are not requiring delayed cord clamping, is or may be beneficial, but for those who are requiring, there is no high evidence to perform early or delayed cord clamping. So we still need further research.
Thank you.
Let me ask only one short thing. So do you plan to include only RCTs for the second project too?
Yes, I think we will include only RCTs. For the first one, we also have observational studies as well, but only one. So we decided to put that in the review and not to the meta-analysis. And we will see the type of articles for the second project as well. And after that, we will make the final judgment. But thank you.
Regarding the grade of the IVH, is there any difference between if it's a preterm or a term neonate? So if it's there something that you have mentioned during the literature search based on the grade of IVH?
Yes, thank you for your question. As we know, IVH is mostly occur in the preterm infants. So in these 4 spots where we examined the IVH, there are only studies which examined the population below 32 gestational weeks and not the term ones.
Thank you.
Is there a difference in the resuscitation of premature and the full-term babies?
The difference can be depending on the condition of the baby. As we know, the prematurity needs a higher level of resuscitation after birth. So I think, yes, they need higher level of resuscitation.